Welcome to the Explainer. Today, we're taking a deep dive into the macrolide antibiotics. These drugs, they're really a cornerstone of our antimicrobial toolkit, all defined by that unique macrocyclic lactone ring. So over the next few minutes, we're going to unpack everything, their clinical uses, the dosing strategies, and a really critical topic, the challenge of antibiotic resistance.
You know, this quote right here, it really hits the nail on the head. To use macrolides well, you have to think like a surgeon. It's not about using a sledgehammer. It's about precision, about targeting the right bacteria in the right patient. That's the key.
So here's our game plan. We've got 6 sections. We'll start with a quick introduction, then get into the nitty-gritty of indications and safety. After that, we'll cover special populations, tackle the huge topic of resistance, and then we'll wrap it all up with a quick knowledge check to make sure it all sticks. Okay, let's jump right into section 1. Before we get to the how and when, we need to be crystal clear on what we're actually talking about. What defines a macrolide? So at its heart, a macrolide is all about its chemical structure, that macrocyclic lactone ring. And the 3 big players you're going to see over and over in practice are Azithromycin, Clarithromycin, and Erythromycin. And even though they're all in the same family, you'll see they each have their own kind of personality and clinical role. Right, now for the practical stuff. This is where the rubber meets the road. It's all about the when and the how. How do we match the right drug to the right bug at the right dose to actually get the job done? Okay, this table is fantastic because it really lays out the distinct lanes for each of these agents. Yeah, there's some overlap, you see it there with atypical pneumonia, but their main jobs are pretty different. Azithromycin, it's a workhorse for things like Mycoplasma genitalium and chlamydia. Clarithromycin, you're thinking H. pylori eradication. And Erythromycin has this very specific, incredibly important role for Chlamydiophila passitaceae in pregnancy. So let's run through a quick case. You've got an adult patient, uncomplicated Mycoplasma genitalium, no known resistance. The regimen for azithromycin isn't just, take this for a few days. It's a very specific front-loaded strategy. You hit them with a 500 milligram loading dose on day 1, and then you follow it up with 250 milligrams a day for the next 4 days. That pharmacokinetic profile is absolutely crucial for efficacy. Now, let's look at a different bug, say gonorrhea. The whole strategy flips on its head. Here, you might use a single, massive 2,000 milligram dose of azithromycin. But, and this is a big but, you're dealing with a major trade-off. A dose that high comes with a high price in terms of GI side effects, and your patient absolutely needs to be warned about that. And that brings us perfectly to the safety profile. Prescribing isn't just about efficacy, it's about understanding the potential for harm. Macrolides have a distinct safety profile we have to navigate: side effects, drug interactions, and the absolute contraindications. I love this slide because it shows such a key point of difference. When you're thinking about macrolides, the big scary thing on your mind should be QTC interval prolongation. That's a cardiac risk that can lead to torsades de pointes. Now you compare that to clindamycin, and the big scary thing is completely different. It's the massive risk of C. diff colitis. Yeah, both can upset the stomach, but the nature of that most severe risk, totally different worlds. Okay, drug-drug interactions. This is a huge deal, especially with clarithromycin. Just look at this list. It is a potent inhibitor of the CYP3A4 enzyme, which is, well, it's a major highway for drug metabolism. So if your patient is on something like tacrolimus or digoxin, adding clarithromycin into the mix isn't a small decision. You are committing to very, very careful drug monitoring. And then you have the absolute no-goes, the hard stops. A known allergy, obviously, that's number 1. But beyond that, that cardiac risk we talked about, it becomes an absolute contraindication in some cases. You would never, for example, give erythromycin with another drug known to prolong the QTC interval, like estamazole or cisapride. That's just asking for trouble. All right, let's dial in our focus even more now and talk about special populations. The standard rules don't always apply when you're treating pregnant patients or children. This is where clinical nuance is everything. And it's worth noting, the sources for this explainer didn't give us specific guidance on macrolides and lactation. which just goes to show you always need to consult specialized resources for those kinds of questions. So let's take a pregnant patient. The choice of drug becomes incredibly specific. For an infection like psittacosis from Chlamydia felicidicea, erythromycin is the recommended agent, period. But this slide also shows us that for something else, like meningococcal prophylaxis, a macrolide isn't even the first choice. You'd go for a non-macrolide like ceftriaxone. It's all about context. And what about kids? Well, in pediatrics, the golden rule is that one size absolutely does not fit all. For azithromycin, you have to calculate the dose based on the child's weight. And this slide is a great reminder of a key contraindication for a related antibiotic. Doxycycline is generally a no-go in kids under 8 because of what it does to developing teeth and bones. We've now come to what is, without a doubt, one of the most serious challenges in all of modern medicine: antimicrobial resistance. The effectiveness of these amazing drugs is constantly under threat, and it is on all of us as clinicians to protect them through smart stewardship. So this is it. This is the question of our time in infectious diseases. It's a massive, complex problem. But one of the most powerful things we can do, right there at the bedside, is to be strategic. It's not just about picking the right drug to start. It's about knowing when to pull back and narrow our therapy. Resistance can sometimes feel like this big, abstract cloud. So let's make it concrete. This 5% resistance rate for clindamycin is a real number. And we see the exact same thing happening with macrolides. Resistance in bugs like Streptococcus pneumonia, a bug that causes pneumonia all the time, is a real and growing problem that changes how we have to treat our patients every day. So what's our strategy? What's the playbook? It's de-escalation. Think about it. A patient comes in, they're incredibly sick, you don't know what they have. It is totally appropriate to start with the big guns, something broad spectrum like meropenem. But, and this is the most important part, the moment the lab calls with culture results with an ID and susceptibilities, you have an obligation to de-escalate. You switch to the most targeted, narrowest drug that will work. That's how we save the big guns for when we truly need them. All right, we have covered a ton of information. So, to help lock in some of those really critical takeaways, let's just run through a quick knowledge check on some of the key clinical points we've talked about. But first, after all that serious talk about resistance, how about a little moment of levity? Why did the antibiotic break up with the bacterium? Because they just couldn't find common ground for resistance. Okay, on to our first question. Question 1. What's the right starting dose for azithromycin in an adult with uncomplicated M. genitalium? The correct answer is C. Remember that front-loaded regimen, 500 milligrams on day 1, then 250 for days 2 through 5. That specific kinetic profile is what makes it work. Next question, what's the word on long-term macrolide use for chronic rhinosinusitis? The answer here is B. It's generally not advised. Yeah, they have some anti-inflammatory effects, but the benefits are just too uncertain to outweigh the very real risks of QTC prolongation and GI problems. And our last question, which macrolide do you reach for to treat chlamydophilomycete in a pregnant patient? The answer is C, erythromycin. And this question perfectly sums up our whole discussion. This is why precision matters. In these special cases, making the right choice is everything. Mastering these details is what lets us use these powerful drugs not just effectively, but safely. Thanks for joining this explainer.